Can everybody see my screen?
Yeah.
Amazing. Okay. So your case this week, this lady is a 44-year-old Gravida 2 Para 1. She had an SVD in 1999 at 40+4, which was uncomplicated. Medical history includes being asthmatic with a BMI of 29. She had influenza A in pregnancy at 24 weeks, and she was admitted on the general side for poor symptoms. At 26+6, she was diagnosed with GDM, which was diet controlled throughout the rest of her pregnancy. And at 37 weeks, she had a growth ultrasound, which showed oligohydramnios and reduced growth velocity. So the plan was for her to have an induction of labour. She was admitted to Hope Ward for an induction of labour for maternal age, GDM, which was then now on metformin, oligohydramnios, and reduced growth velocity. So 4 risk factors there. On the 16th of the month, I haven't included all of the CTGs, guys, because there's so many on this lady. But I've just included the ones from antenatal ward, from labour ward. So on the 16th at 19:25, her ProPES was inserted and OS was closed. I think her Bishop score was 1 or 2 at this point. And then on the 17th at 20:10, the ProPES was removed and she remained 1 centimetre. It wasn't noted whether or not this was an ARMable cervix. But I think the plan was for her to have prostin. At this point, she was irregularly contracting, so they couldn't give it. So she was just left to sort of crack on by herself without us giving anything extra at this point. At 22:30, her observations are done, and mum's heart rate is 160 beats per minute on the Dynamap and 146 beats per minute manually. So the registrar comes to review her on Hope Ward, recommends transfer over to Labour Ward, and fluids are started before she's transferred over. So this is your CTG when she enters Labour Ward, transferred with the first bag of Hartmann's, which is running. Pulse remains 140, blood pressure is normal, so is her temperature. An ECG is performed, PET bloods are taken, and a lactate is taken. I'll show you the results, and the results for these are on the next couple of slides. Also, apologies, I'm probably going to sneeze the whole way through this review because someone's cut the grass outside the hospital today. So yeah, any questions? Are we happy with this CTG?
What was the baseline on the previous CTGs?
Baseline beforehand was like 130, 140.
So similar to what we sort of got now.
Yeah.
Yes, good. What's she contracting? Is she feeling these?
Yep, so she's tightening, but not really feeling them very much at the moment. Not requiring any pain relief at this point.
Thank you.
Cool. So we're happy that this is a sort of an accelerative trace, or are we querying anything else?
No,
Okay.
I would agree.
Yeah, normal.
Perfect. Okay, so this continues for a wee while. Baseline reduces down to sort of 120 beats per minute. And this continues for a while. So it's now the 18th. So apologies, she's now 38 weeks. So she's 38 weeks now on the 18th. Sorry, 38 plus 1, my bad. Pulse remains high at 142. Blood pressure still remains normal. Still got stable baseline, sort of sat at 120 with accelerations.
The acceleration.
Sorry,
in conjunction. Sorry, go on.
No. I wanted to ask, this heart rate of 142 was deemed as what? As
so like... the ECG showed sinus tachycardia, Mr. Naguib, on the ECG, but a bit later on, a medical review is requested, which is on the next couple of slides. And that was the plan that was made by the obstetric registrar.
Right.
Saoirse,
Thank you very much.
That's okay. Saoirse, what were you going to add?
So if you're looking in the CTG, just looking at the TOCO, every time she does a contraction, it seems like the fetal heart is having an acceleration as well. So in theory, she's contracting 3 to 4 in 10, and this acceleration every time. I mean, beforehand, I was reassured because there was cycling. But you're 1 centimetre, you wouldn't put an FSC on, I assume. She hasn't stronged.
No.
But I would be manually palpating and potentially ask for a scan, because I wouldn't be 100% happy about the fact that it could be reassuring, but also with the heart rate at that high as well, and you haven't got the pulse oximetry on the CTG either.
Yeah. Yeah, we're having some issues with pulse oximeters on labour ward at the moment, because everybody keeps breaking them. But because we're getting new monitors, we're not going to be purchasing any more for the time being. This lady, I think, had the pulse ox on from the Dynamap on permanently, but all of the observations that were taken throughout the entire time this woman remained on labour ward are all in my slides.
Sorry, Cara, to interrupt again.
That's okay.
She's para 1, previous normal
STG,
delivery.
yeah, in 1999.
Right, so we are more than 20 years ago.
Yeah.
Okay, fine, thank you.
Yeah, her first child will be 24 this year.
And
So
this one is IVF.
No.
Okay, fine.
No, not IVF. Your risk factors for this lady is maternal age, oligohydramnios, reduced growth velocity, and GDM on metformin.
Brilliant. And the baby is on what centile?
I think the centile was normal. I think it was about the 60th.
Okay, right, thank you.
But then you're thinking reduced growth velocity. So what was it on before? And then also the fact that it's oligo as well. So we're thinking the kidney function and the placenta isn't working. Is the GDM well controlled?
Well, she got put on metformin, I think, maybe 2 or 3 weeks before delivery. So I think she went on to metformin reasonably soon after. So I'm going to assume no. But with the metformin, I think her BMs were all within normal ranges.
Okay, thank you.
Perfect. So at 0040, I think the registrar has spoken to the medical reg on the general side at this point, and additional bloods are taken. So they took a bone profile and magnesium, usinase, LFTs, clotting, troponin, and an FBC. These all came back, as you can see here. So pulse still remains high at 142. Her troponin, I'm not very, very good with the parameters here, but I know that it's supposed to be less than 50. Mr. Naguib, correct me if I'm wrong. Her INR was 0.91, platelets 186, HB 135, and white cells 12.6. So that's the results that we've got so far. And I think her blood gas was normal.
Stupid question coming from a midwife who is not a nurse, but why should we be looking out for certain things? If we're taking those bloods, are they worried about certain aspects? Infection, it's completely normal now, so I take it back. But in the sense that if they're taking those bloods, what are we looking for?
So more or less, they are looking at conduction problems by having magnesium. So the magnesium, the troponin for any kind of heart failure, kind of, so they are looking at signs of atrial fibrillation, ventricular fibrillation, signs of, so more or less they are trying to anticipate the next move of this heart, and whether it is a heart that is going to more or less succumb under the pressure or not, especially in pregnancy.
Okay, thank you.
And the way that this is something that was very, very, very new to me when I looked into this one, but you get a very high troponin level when you've had a heart attack. And hers was raised. It wasn't quite as obviously dramatic as somebody that has had a heart attack, but hers was raised, and it's all to do with proteins in the heart muscle, essentially.
Interesting, thank you.
Which was a fun fact I learned last week. Yeah, so she's been reviewed by the medical team. They've reviewed all of her bloods. Her ECG was repeated and was normal, sinus tachycardia, and they can't find anything that's majorly drastic from her blood results either. So the plan that was made was to start, the plan that was made was to start a bag of saline with magnesium in it, which is started a little bit later on. I think there was a delay in giving this due to the fact that this is something that obviously we as midwives don't give on the regular. So just making sure that we're double and triple checking before we're giving these sorts of medications. But the CTG remains pretty similar throughout. And then baseline again, sort of 125. We do have a slight period here of reduced variability, but I think this is most likely due to cycling. Baby's had a very active period so far. So yeah, and the medical review queried ABNRT with an unknown cause.
What happened to the taco?
The taco is apparently still on. The taco
picture it upside down.
Yeah. The taco hasn't been adjusted. There's nothing in the notes that says it's been adjusted, and there's also no report at this point of any sort of maternal discomfort or any report of contraction, so I unfortunately wouldn't be able to tell you. And this carries on for quite a while as well, and even with women that aren't contracting, we normally see something other than a straight line, so I am going to assume that it was probably upside down. But yeah, her pulse came down to 97 at this point, which was good. And then at 0600, they started magnesium sulfate, 50%, 8 millimoles in 250 mils of normal saline. Everybody happy with the CTG?
Yep.
Yeah, I think
Lovely.
it's just that human factors where we're not even looking at the taco because we're probably stressing about the medication. I think that's probably what's probably in and out of the room trying to figure out where 50% magnesium is. And I think that's the priority rather than the actual taco. So
yeah,
but you should still be palpating every hour, like, so just being aware of that as well.
This is something that I mentioned in all of my study days. I'm not sure how many people that are on this call have been on them, but we're finding that a lot of people are missing out on reporting palpating resting tone in between contractions, as well as actually measuring them themselves manually, as opposed to just relying on the tech. We love it, but you know, going back to our basics, it's one of the first skills we learn as student midwives. So it is really important to make sure we're doing that for at least 10 minutes within our labour care. Obviously, at the moment, she's an antenatal lady, but obviously we're giving her additional support with a few things. So it's really important to not forget those key skills. Okay, we continue. Not very many changes at this point. She goes out to the toilet and passes a good amount of urine at 04:30.
I feel Cara.
Yeah.
I don't know. Maybe because I am on my phone. We started with 140.
Yeah.
Has gone to 120. Now we are 110.
Mhm.
Am I right, or it is?
Yeah, no, you're totally right.
Does the medication affect that?
Yeah, so that was what I was going to say. Like when we give magnesium sulfate, we know that can have massive impacts on our CTG. So quite often it will reduce variability, which I guess you could kind of see from this. But in terms of baseline as well, yeah, it most likely is due to that. But it's quite a significant difference to have gone from a baseline of 140 to a baseline of 110. I know that medications can have that impact, but it's quite significant.
I don't see that with magnesium sulfate alone. I think the extra magnesium that we are giving is having this impact rather than only the magnesium sulfate. It is the extra magnesium in the saline.
Yeah.
Yeah. Okay. Fine. I'm not sure though. I would be so much relaxed from 140 to 110, you know, like completely with, I mean, on balancing all what you said about 24 years ago, on balancing GDM, on balancing pulse of 140 and being investigated, on balancing on being on magnesium. I'm not saying that CTG is dreadful, but if I'm looking at the whole woman, I feel that I'm starting to be out of my depth here. I don't know. Maybe it's me.
Yeah, I think the team did absolutely the right thing in getting the medical review involved, because there's been another case recently where we had another lady with an incredibly high resting heart rate who didn't have any further investigations. So I think that was a key message that went out, and I think this is a result, the fact that we've managed to get the medical team on board for review. I think the fact that they didn't have any specific concerns may have been more reassuring from a maternal perspective, but like Saoirse said, if we think of the human factor element of it, you know, we've spent a lot of time worrying about mum and getting her sorted, that this may have been something that wasn't as picked up. Also, if you look at the timestamp, it's now 4:50 in the morning.
Cara, I thought you said earlier the magnesium wasn't given till 6.
No, it was given before that. I think I've put the timing in wrong.
Okay, fine.
I'm pretty sure. Yeah. So we continue like this for a little while. This is about an hour now of the baseline being 110. It kind of comes up a wee bit to about 115 towards the end of this CTG here. Still accelerative, still got a stable baseline with good variability, but yeah, I think I'd definitely sort of be more cautious about it. But all sort of factors of it, if you like, would be normal. This continues again. The ECG is repeated at 6 a.m. Again, is normal at this point. Blood pressure is normal. Pulse is 89, which is good. And temperature is 36.4. For some very strange reason, the Dawes-Redman criteria was used on this CTG. I don't know how many times I have to mention the fact that we don't use Dawes-Redman after an induction before the message comes across and we stop doing this on a weekly basis. But yeah, Dawes-Redman met criteria. I haven't included any of the further details because it's completely irrelevant when we can clearly see that this woman's having uterine activity. Just realised that.
Do you reckon they did it for the STV value? Like, do you reckon it's because they were worried about the magnesium, the variability? Do you reckon it's just that point of view? I'm just being devil's advocate, like.
Yeah, maybe. But and you know, technically, yes, she's an antenatal lady, but we've given her hormones to induce her labour, and she's contracting. So whether or not they're trying to get an STV, it's completely inaccurate.
Yeah, I agree.
You know, so there's key messages that have been out about this, and there's posters everywhere about the fact that CTG, Dawes-Redman analysis should not be used on anybody post-induction, or anything like, or post anything really. Specifically as well, you've got uterine activity, which the TOCA has clearly been adjusted. But yeah, we've really got to stop this because it's an antenatal tool, and this lady, although she's less than 4 centimeters, doesn't mean that, you know, we've interfered. So therefore, it needs to be stopped. But yeah, so oh god, there we go. Sorry, she's taken off the CTG at this point to give the lady a bit of a break. And then she's put back on at 0750. Her CRP and troponin were repeated at 740. Her CRP was rising and is now 19. Troponin had gone from 52, I believe, up to 64, so an increase. This is the first BM that's been recorded throughout the entire process as well, which was 4.3, so nice and normal. But blood pressure remains stable and her pulse is also normal at this point. And again, not really many CTG changes. Any questions, anybody?
Can you quickly run through the dilatation so far?
So far, Mr. Naguib, we've been Bishop score of 2, and we haven't been re-examined yet. So we're Bishop score, we're 1 centimetre, and that was about 12 hours ago. 10 hours ago, sorry.
Thank you.
But yeah, no repeat VE's been done on this particular night. So we continue. CTG stopped after this hour, was classified as sort of normal, and again she was taken off for a break. At 10:30, she is examined and found to be 1 centimetre dilated. The day ward round is performed at 11. Registrar review. The plan is to give her 2 milligrams of Prostin and then VE her 6 hours afterwards. And to also ensure, this was actually stated on both registrar reviews, to make sure that she has a cardiology follow-up postnatally. Pulse again remains normal. Temperature's dropped a little bit to 35.7. BM is normal. Blood pressure also normal. And she's given 2 milligrams of Prostin at 11:30. And this is the CTG following. That's a full hour. So the CTG has stopped, and she's getting some discomfort now. So dihydrocodone and paracetamol was given to this lady. Few hours later, about 4 hours later, she's put back on the CTG. Note how our baseline is now 140 as opposed to 115.
Has the magnesium stopped now?
Yeah, it has.
Ah, okay. So maybe that's why.
Yeah, so it does make total sense, doesn't it? The fact that that's brought it down completely, and then it's sort of gone back up to its original baseline again. I just thought that was quite bizarre, because it's a significant increase and a significant difference of 25 beats per minute. Like I know the effects of it, but it just was a bit bizarre for me.
So was the magnesium running for this whole time, for like the past 12 hours, even longer?
No. So it was running slowly. I can go back to the slide. Sorry. That was at 3:30. Do you know what? I don't know what rate it was running through at, I'm afraid. It was over a good couple of hours, but this is 12 hours later. Although you'd think, wouldn't you, that there would definitely be some after effects of it, so it wouldn't just be stopped and then completely be out of her system. You'd feel the repercussions of it for a good couple of hours after it had been stopped. We continue. This is classified as normal, so she's taken off the CTG. Do we agree?
We agree, but again, we are still in the process of induction.
Yeah, still proceeding with caution.
Like what? We are prostating her more, or what are we doing?
So the plan was for a VE 6 hours after the Prostin. So the plan was for VE at 18:30.
Okay.
So at 7 p.m. she is reassessed and she is 1 centimetre dilated again. So second Prostin is given, and they've given 1 milligram this time. And this is your CTG following Prostin insertion.
Yeah, okay.
Okay. It continues for a wee while. And then after an hour and a half, the CTG is stopped.
There's something about this CTG that I don't like, but I don't know what it is. And the CTG is normal, and I don't know if it's just because of her history and the fact that she has. There must be something underlying, but I just don't. I don't understand the physiology of this. I don't understand why. Yeah, but it's normal. So what are we doing? What are they going to start Synto? Are they going to ARM? Are they just going to keep giving Prostin? What?
So So the last Prostin obviously was given at 7. So the plan from that Prostin, I believe, was to reassess in 6 hours. So 8, 9, 10, 11, 12. So 1 o'clock in the morning. But the obstetric team come on in the night shift to do a ward round in a second. So CTG stopped at about 8:30.
And her pulse at the moment is fine.
Her pulse at the moment, they didn't do one, Mr. Naguib. So every single set of obs that were done on this woman are in these slides. So she's not had her pulse checked since 11:30 that morning.
Okay.
I think we've gone to the assumption of she's an induction of labour for blah, blah, blah. She only needs her obs done like they do on Hope Ward every 12 hours unless there's blood pressure issues. That would be my assumption here. But yeah, all obs that I've actually done are included in my slides. So yeah, we've now been, well, 9 hours, sorry, 7 hours without taking a maternal pulse after we've given magnesium overnight for fetal for maternal heart rate concerns. So sorry.
It'd be interesting to know where baby's heart rate's gone up, mum's heart rate must have gone up as well. It would just be interesting to look at that.
Yeah, exactly. So she's taken off the CTG at 8:30. The obstetric team come and review her at 8:45. The plan is for exactly what we said, vaginal examination at 1 o'clock in the morning, and a CTG to be restarted 30 minutes beforehand. And again, just clarified to this lady that she needs to go for a cardiology referral postpartum. The CTG, however, was recommenced, I think, just for the purpose. I'm not really sure why this was done for 20 minutes. I don't know whether the midwife was concerned with the previous CTG and wanted to continue it or not. But this is just a quick 20-minute segment here.
She feeling that uterine activity?
Yeah, she's getting more, she's feeling the contractions more now. Not quite enough to sort of request further pain relief just yet though. So at midnight now, so we're now on the 19th. So she was admitted on the 17th. So we're now on the 19th. She's given some paracetamol orally at 0005. The case midwife for this lady is helping out with another patient in theatre. So this call bell was responded to by a different midwife. Blood pressure 120/67 and pulse of 99 at this point, and her temperature was 37.7. She was getting a little bit uncomfortable with the contractions, so I think the paracetamol was given for that, but also as well as the temperature. Very low grade, but yeah. What are our thoughts here? What's the baseline now?
I prefer it. There's something happening. Makes sense. You've got a rising baseline. You've got one deceleration there, another one coming up, sort of potentially a chemo.
Yeah.
It's sort of in conjunction where she's at in labour though. She's 1 centimetre. Just from the previous CTG though, she looks like she was hyperstimulating, and then now we've got some sort of reaction to it. But yet the uterine activity doesn't seem to be holding up. So I think she's probably contracting more than it's picking up. And you've got some fetal response, but also you've got a baby that's oligo. So the slightest sort of uterine activity, you're going to have some more intense reaction. She's got reduced growth velocity and the placenta's not as sufficient. She's also got GDM on board as well, and then some weird cardiac problem that we don't know really what's going on there. So any sort of slight change here warrants, I need a reg review. I want more support here, because this little change actually could it be indicating something a bit more.
Yeah, what's your plan then?
Right. So I want a reg review, definitely, or definitely a doctor review, and internal set of observations. So she's tacky slightly at 30. Well, we don't know. This heart rate's confusing me, but 37.7. Yeah, low grade, but also I don't know. Did we do a CRP? I potentially would be thinking infection with a rising baseline as well. But the heart rates keep confusing me. Did we do any rests anywhere, or we don't?
No, all the rest were either 18 or normal.
All right, okay. So we're probably not taking them properly.
No.
It's so you could be on the verge of actually maybe some choreo. I don't know, but I definitely want to reg with you, and maybe borderline. I'd keep observing those observations, do them more regularly, and potentially like screen and treat, do a septic screen.
Yeah. Anybody agree or disagree?
She's had a temperature of 35 as well. Just to point out, we can have a low temperature that indicates septicemia's, infection as well. It's a very weird one.
It is, isn't it?
Yeah, I would personally do the examination earlier than 1 o'clock.
Yeah.
And inspect whether I can, see where are we. I would be slightly reluctant to give terbutaline, not because of anything, except that we might have some effect on the heart, and we are already playing with the heart too much here. So, but I would like to know exactly where am I in the VE.
Yeah. Okay. So at 01:20, the cervix is examined by the case midwife, who's now returned from supporting in theatre, and the client is requesting pethidine. The registrar at this point I don't think they reviewed with the person because they were in theatre at this point. But the recommendation by the registrar was for pre-meds and IV antibiotics.
Yeah, so the thinking of the registrar at the time is to prepare in case they want to go to theatre, isn't it?
Yeah, exactly that.
Which is a good thinking.
Yeah.
And the IV antibiotics again. So we are thinking 37.7.
Yeah.
We are thinking possible choreo growing. Yeah.
Yeah.
Very good. Okay. Yeah.
Yeah. So at 01:40, pethidine is given IM. And at 01:50, she query Shrum clear Lycor. This was noted as she was moving on the bed preparing for an obstetric reg VE, who also found this lady to be 1 centimetre dilated. What do we think? What are we going to classify this as now?
Antenatal still, so abnormal.
Antenatal normal.
I would go for suspicious, to be honest.
Abnormal, because it's an antenatal trace.
She's antenatal.
But abnormal?
Yeah.
Yeah.
Abnormal. Yeah. We've also I just realized you guys will see this one.
We can't really say it's antenatal. She's contracting, so I wouldn't say it is going to abnormal, and I would say it's suspicious if we want to do any classification, really. But she is contracting, so she is. I would say even if she is not in active labor, she is in latent phase labor, really. So, yeah.
Yeah. Let's put it this way: if this was a CTG that you were seeing on Hope Ward or antenatal ward, we would immediately recommend transfer to labour ward, because this would not be a safe place for this lady to be when the midwife is looking after multiple other women.
Yeah, definitely.
But she's in labour ward, isn't she?
She's on labour ward, yeah. But if just as a sort of side note, if for example she was on Hope, then this would be a necessary transfer. Okay, so at 01:55, the obstetric registrar makes the decision for a caesarean section for failure to progress and query chorioamnionitis. Her pulse has now gone up to 103. Her respiration rate is 20. Temperature is 37.0. Blood pressure remains normal. And at the end of this CTG, she's transferred over to theatre at 02:25.
Yeah, we agree that the decision is absolutely right. If I add on top of it the cardiac situation, if I add the GDM, if I add the oligo, if I add the, you know, if I add that she's 24 years since her last delivery. So, I mean, overall, it is the right thing. Yeah.
Yeah. Yeah, absolutely. Also, we've got these chemoreceptor decelerations at the beginning of the CTG here, and they're getting more prolonged towards the end of the trace as well. So I think the decision was made within very good time as well. This is your CTG in theatre. So she has a spinal placed at O237. So well done to the midwife for maintaining the monitoring throughout this. This was a very proud moment for me. O251 knife to skin, O258 knife to uterus, and delivery was 1 minute later at O259. And this lady's EBL was 650 mils. Anyone want to comment anything on this CTG?
Beautiful example. You can see that slow descent, can't you?
Yeah.
You said with bradykardiogram, bam, straight down to 60. You can see this baby's slowly reducing its heart rate. And actually, it's a really good example to show that. Good shout.
Great shout. Anyone want to guess the gases?
Seven point one.
7.1.
Go on, Nagib.
7.1. Yeah, 7.10, 7.2.
Yeah.
Anyone else? I know there's more than Nagib and Sorsha on this call.
7.15. Sorry.
7.15.
And 7.2.
Okay. Anybody else?
I reckon the lactate or the lactate's going to be higher, and I reckon the basic cis might be as well, just because of the sort of what's been going on with mum as well, and how mum's cardiac output is going to affect this placenta as well.
Yeah, 100%. 100%.
Yeah, it'll be interesting to see this fetus, how it turned out.
Well, I'll put you out of your misery, although you're all aiming a little bit high. This baby had APGARs of 9, 9 and 9, but the gases, the arterial was 6.98 and a base excess of -13.6 with a lactate of 8.4. Venous pH of 7.05, base excess of -11 and a lactate of 6.7. Nasal flaring was noted with this baby at 8 minutes of life. It didn't need any additional resuscitation at birth, and actually delayed cord clamping was maintained in theatre as well, which was excellent. The baby was kept in SCBU for 45 minutes just for review. The repeat gas was normal at 7.2, and a normal neurological exam as well, which was great. Any questions?
So that last bit of the trace in theatre was possibly subacute hypoxia, yeah?
I would go with acute because it doesn't actually come back to the baseline at all if we're considering the baseline to be where it was before at 140. But to be completely honest, that obviously will have affected the arterial pH. But in terms of the high base excess and high lactates, this sort of is indicative of a baby that's been under somewhat of a distress for a while.
Chronic.
Not necessarily chronic, but here I mean, if you want to be highly technical, depending on where your baseline is with this specific segment, the baby does only come back up for a little while in between those sort of chemo-like decelerations. So I think the timely transfer was really good, because if this had been continuing for much longer, we would have probably had quite a different outcome.
So well done to the team.
Yeah. Any other questions at all, guys?
You said that the scan was showing that baby was on the 60th centile, isn't it?
Yeah.
Okay.
Yeah. Perfect. Well, thank you all very much. Thought that was quite a good one for you.
Absolutely. Thank you so much. And thank you for the presentation and for the team as well. Thank you.
Thanks, everyone.
Thanks, Cara.
Thanks, Cara.
Thanks,